I'm Thomas Land Abrahamsen. I'm head of the support efforts in the homeless unit in the city of Copenhagen. I've been working with marginalized adults in different settings at the municipal level in the last 8 to 9 years. With me, I have 2 colleagues that also works with those methods in regard to housing first. Before we go on, I will give you a super short look into how we see the analogies of homelessness in the city of Copenhagen. Roughly, it can be divided into 3 stages depending on the cause of the individual. We talk about a before homelessness. This is where all the risk factors are present, such as the range of the social problems, evictions, the inadequate help, poor economy, transition from childhood to adulthood, release from prison without proper housing solutions, etc. Not to say that all these risk factors will lead you directly into homelessness, but they are certainly risk factors that we need to be aware of, and they should be addressed as early as possible. And Louisa will tell you a little bit about how we try to prevent that these risk factors will put you into homelessness in the first part. When we do not succeed, we have the second phase, which is homelessness. This is where one can be a rough sleeper, staying in a shelter, an emergency shelter, be a couch surfer, being in prison without a housing solution, and this is where we need to find solutions afterwards. And in order to target our citizens' move from homelessness, we have different possibilities depending on the extent of the problem. And we have institutions with permanent social institutions with permanent accommodation. We have special housing for former homeless with ordinary lease, and then we have one would call normal housing apartments with ordinary lease. For the vast majority of our homeless population in Copenhagen, ordinary housing with adequate support seems to be the best solution. And it's here our approaches to housing first comes into play. And that's what we're going to talk about here, the different support methods. We could use hours talking about the whole housing situation and how they are difficult to get, but our main focus here is the support factors. But before we go into those, I would like to highlight two pointers. The one thing is that the only thing that is the same for all people who end in homelessness is the lack of a home. But this is not what makes it necessary for us to come and support this transition. It's all the other dimensions in the life of the individual in one way or another, or in combination, that needs the attentions from us. And the other thing is that we're looking at when offering our support in the context of housing first is the motivation, which is crucial for this success. It's not that, of course, everybody is motivated for a better situation. Therefore, we have tried to break this concept of motivation down to the willingness to change. And the ability to change, and the belief in one's own abilities, and also the readiness. We use this assessment to what extent we will need to support the individual. In essence, which methods, CTI, ACT, ICM, or one of the other methods of support we can apply. And one of them are CTI, which Louisa will tell you, and Louisa will tell you a little bit about.
Yeah. So CTI stands for Critical Time Intervention, and it's a systematic, phased and time-limited method. developed to support people in critical transitions. Originally, the transition from homelessness to life in their own homes, but gradually tested successfully on several critical transitions in the lives of vulnerable people. The method is based on a recovery and empowerment view on the citizen, and the process is planned in collaboration between citizen and CTI employee, and is always based on the citizen's own wishes for change and support, and with a great flexibility in terms of both content and scope. At Hybelinstitutionen in Copenhagen, we have been implementing critical time intervention in the transition between child placement and independent lives in your own home for the past 2 years, with a focus on preventing young people from ending in a homeless situation. The most important basis for the work is to teach the young people to master their living conditions in the best possible way. Among other things, by working to anchor the learning they have developed during the placement in their independent adult lives. We have incorporated a more therapeutic approach and understanding into the critical time, into the CTI method, based on the understanding that many of the young people's challenges stem from the neglect they have been subject to. Our staff is therefore trained to look behind the young people's behavior and support them in experiencing new forms of interaction in relationships. The young people, so to speak, practice in relation to the CTI employee, and the CTI employee also acts as a coordinator in the young person's life to other support systems. So we see it as a training arena to work to get new interaction experiences, and then we follow out to the other support systems, out to the family network and other places where the young person will need support in order to achieve a better way of managing their adult lives. At the same time, we have a strong focus on the family network and the young people's networks in total. We often see that there's a distance between the young person and his or her family after the years of placement. There are unresolved conflicts, and often we see a lot of misunderstandings about the original reason for the child placement. During the 2 years that the project has run so far, we've seen that we can succeed in re-establishing the family relationships, among other things, through working with translating intentions on both sides of the table, and through secondary family work aimed at teaching the young people to manage the relationship to their families. Would you change?
Yes.
Thank you. So we've been implementing critical time intervention for 2 years, which means we have a very small scale of experiences with using this method in this particular transition. We have completed approximately 15 critical time intervention courses, and only one of the referred young people have not completed, as he moved to another municipality. All of the other young people have actually succeeded in keeping their home, just as all young people have achieved attachment or maintained an attachment to either education or the labour market. The most important thing to emphasize, however, is that all young people have achieved a higher degree of mastery of their own lives, and the majority manage to live their adult life without support from social services after completing the CTI course. This is not a goal in itself. CTI never closes doors, but of course, a lot of our young people have as a goal for themselves to be able to manage life without help from us, basically. Would you change again? Thank you. So I wanted to introduce one of the young people that we've been worked with. He was a young boy of 18 when he was referred to the critical time intervention course. He had just been offered youth housing, and had been placed in child placement since he was approximately 12 years old. First at boarding school and then in cohabitation with other young people who had severe and complex problems. Both of his parents came from placement backgrounds themselves and had received transfer payment for most of their adult lives. When we started working, he didn't have a lot of experience being a part of so-called normal society. He didn't have abuse or behavior that raised much concern anywhere. On that note, he was different from a lot of the young people we work with. But he did have difficulties getting started on education or jobs, and often isolated himself in his own home, just as it was difficult for him to manage his finances. He had 3 wishes for his critical time intervention course. He wanted a job, a house, and a wife. Therefore, the initial work together with him was to split his goals into sub-goals and to further define what the support to achieve the goals could actually include. In that prospect, he's a lot like a lot of the young people that we work with, seeing as that he lacked a language to explain his inner life, to speak of his hopes and his dreams, and therefore he often ended up saying yes to offers from job centres and other support systems, even though he didn't actually want the offers that he got. So when they would say, would you like to become a carpenter? He would say, sure, sounds like a great idea. And I would actually help him translate, is that in fact what you want, or do you have different dreams? So a lot of the work with him was actually trying to achieve a greater language for his dreams and his goals, so that he would be able to express himself differently in relationships with his family, but for certain in other support systems. We chose to work with the conveying of inner life through diary exercises, through relationship work, and working with his family around the story that was the basis for his placement, to lift shame and guilt and free up space to also receive care. All the while we involved him in why we chose those goals and how they fit with the goals that he had for the course. How it was a breaking down or a splitting up into smaller goals that were attainable within the 9 months. He's now actually in the military, in the process of becoming a sergeant, and has a close relationship with his family. That didn't come by solely from the critical time intervention, but certainly he was helped in being able to explain and to apply and to actually take the test entering the military. We did not, together with him, manage the house and the wife, but he is in his home, and I am sure that he will manage to find a perfect wife for him on his own.
Thank you. I will now tell you about one of the methods that we apply with when we look into a little bit higher complexity at the individual. It's the individual case management method, ICM, which we call it. It's like the CTI method, a collaborative and planned approach to ensure that a person who experience homelessness gets the services and supports that they need to move forward with their lives. The approach is pretty much client-centered, which ensures that the person who has experienced homelessness has a major say in identifying the goals for the support and also the service needs and also that there's a shared accountability. The target or the goal of the case manager is to empower people, draw on their own strengths and capabilities, and promote an improved quality of life by facilitating timely access to the necessary supports, and thus reduce the risk of homelessness coming back, and also to achieve this housing stability that this is one of the primary aims. The ICM is often long term, and it's time unlimited, so it's depending on the needs of the supports that we discover along the way when we stop the support. Some numbers from our ICM is that the caseload is 1 to 8. So one case manager to 8 adults, and also that the ICM method is in use as part of is in many parts of our support system. Both when we talk about young homeless, who we try to keep in the home, but also long-term homelessness coming from the shelters. It's also the method that our case managers in the interdisciplinary ACT method work with, and it's also used in the continuation of the ACT method that Maria will tell you about a little later. It's not an expensive support method. It's only, should we say, only 40,000 Danish crown, 45,000 Danish crown approximately per year. But compared to the price of shelter beds and all the needs for help you can have at the regional level or the state level, it seems like it's a good bargain. Especially when we look at our results in keeping all the one who get the support from the ICM methods. When we look at how many we have in their own home after they receive support from the ICM case manager, 9 out of 10 stays there. Because we are supporting citizens with comprehensive service needs, which can grab into the different dimensions we showed before, we need to be adaptive to the needs of the individual. An almost ordinary situation or example is that things change when landing in one's own home. When the basic need in Maslow's hierarchy of needs is fulfilled, housing is one of those basic needs. The other dimensions gets room to come forward. It could be an undiagnosed or undiscovered mental illness. It could be an unhealthy network. It could be cognitive challenges which comes to light because there's now a calm in other dimensions of life. But that's also why it's so important with close collaboration with the caseworker with the caseworker of the individual who's such an important part in why we keep on succeeding in keeping our citizens in their own home when they get the ICM. It's because the coordinating caseworker is is the one who regularly follows up on the fulfillment of goals and can adjust those to additional support needs if they should be needed because other dimensions are starting to grow. And in this regard, I would like to highlight our use of network meetings, which is a simple but yet effective tool to coordinate with all the other efforts, which sometimes can be a bit overwhelming for the individual to meet and find his or her own way in. For example, the individual is often a part of the efforts made in the job center. Also maybe in substance abuse treatment, also psychiatric treatment or training teams, or also the relatives, friends and family plays a role. In short, this network meetings help us to coordinate and reach out and do the right matching of services along the way. Now Maria will tell you about how we work with ICM as part of an integrated team called the ACT.
Yes. And assertive community treatment is the most extensive housing first method we have. And I will explain the structure that we have for the team in Copenhagen, which is we have 2 teams with 80 citizens, and one team holds 6 case managers working from 1 case manager has 8 citizens. And then we have 1 caseworker, 1 nurse, half an outreach caseworker from the job center, and half an outreach social worker from the addiction center. And then the team structure creates a comprehensive view on the citizens' problems, and due to the interdisciplinarity in the team, it works in a holistic manner. And with the citizens' recovery, empowerment, and rehabilitation in focus. And this is the very important structure for working with the client. And then the purpose for the municipality is to give the citizen a relevant support in the social and health department, as well as making sure a relevant social and health treatment is established. And then the aim for the citizen is recovery and rehabilitation on their own terms. As you can see on the slide, if you just wait a second, Thomas, there's no psychiatrist, and that's basically due to lack of psychiatrists in Denmark. Otherwise, it would have been a
nice thing to have.
A really nice thing to have, really. Yes, now you can change. The target group in Copenhagen is socially marginalized clients with complex problems such as drug abuse, mental issues to a degree. Then lack of affiliation to the public sector, such as the job center, addiction center, home care, hospitals, etc. And the citizen is not able or find it difficult to follow the ordinary system, and they need outreach social and healthcare services. In the model, there are 7 important elements, and I will especially outline 3. The team is flexible. It's flexible in time. It can be 1 hour a week where it's only the case manager who meets the client, but it can also the next week be 7 hours if you're going to court or have a hospital appointment. So if needed, the team can cooperate in solving the schedule, and due to the structure of the team, this is possible. And then it's flexible towards the plan if plan changes in the client's life. Then the team easily adapts the changes and informs all relevant partners in the municipality. For example, it could be the job center, it could be the addiction center, but also it could be the criminal center or the criminal system. It could be the hospital. Wherever the citizen goes, the team can follow. And that's to make sure that everybody's working towards the same goal. And then it's individually arranged. That means that each citizen has its own path to recovery and rehabilitation. There is no one-way fits all, and plan changes due to changes in the citizen's life. Then it has to be coordinated. So it has to create, and that is to create coherency in the social and health care system to benefit the citizen. The client does not have to fit, the system has to. And now, yes, I would like the next slide. Live life does not follow a linear path. I find this drawing really, the first one, really illustrative towards live life for all of us and also the social marginalized. So I will tell you about a 50-year-old woman with an abuse of alcohol, methadone and benzodiazepine. She has a history of homelessness, living on the street with her dog and in shelters for years. She has her own apartment now, for now, but she wants to leave it due to bad memories and unpaid bills. She is enrolled in the Center for Addiction, but she does not go there because she gets so affected by the surroundings as well as the other clients. This means that she has very little contact with social workers and medical staff at the center. Due to this situation, the ACT team is established because they have the interdisciplinarity that is needed. And the first task, and now I'm going to make it linear, but it's not. But the first task was simple, yet difficult and acute, because her scooter had broken, and therefore she could not walk her dog. So the team stepped in and coordinated a walk the dog schedule and made sure the scooter got fixed. Then secondly, the client was in agony, mentally as well as physically. So she needed to see a doctor from the addiction center. The team needed to investigate the client's perspective in relation to the meeting. The team also needed to establish their own perspective with the knowledge from the client as well as with the knowledge from the systems. And then the team had a preparation meeting with the doctor to make sure there was a coordinated agenda, and the client knew that and agreed. And we also made sure that she could go directly into the office for the meeting. No waiting in the common room. She clearly could not handle that. The meeting went really well, and a good plan was made. And the client left happy and felt that she's been taken well care of for the first time in a long time. Then, next problem was she had several unpaid bills that needed to be taken care of, otherwise she was in risk of losing her apartment. The case manager saw that together with the case worker and the client, because the team can grant the money. And then we started to investigate why she wanted to leave the apartment, because she clearly did not want to be homeless. That was not it. The apartment was messy and dirty, and she disliked that, but she did not have the energy or the ability to change that. But she really needed to be a part of the process of cleaning and creating a sense of home. So again, the team stepped in, helped her with clearing out the trash, clothes, etc., and arranged for her to get some furniture so she could actually organize her life. Afterwards, home care was established to come and clean every second week. So this is just a small view into the complexity of the client's problems and the amount of problems that the team solves. But it shows how the team works together with the client as well as the system, and to create individual plans and solutions. And that was it from me.